Good morning. And before I begin, I'd like to thank Groucho Michel for taking on a new challenge. I know you have many demands on your time, but serving as the chair of the Partnership for Maternal, Newborn, and Child Health, but I think we're really so grateful to you for taking on that new challenge and opportunity. Friends and colleagues, on behalf of Save the Children, I'm very pleased to join all of you here today for this important conference. As many of you know, the issue of newborn health has been dear to the hearts of Save the Children for well over a decade, with much of our work made possible with the support of the Bill and Melinda Gates Foundation and USAID. And since 2000, our engagement in addressing newborn health has really continued with the support of the foundation, but increasingly it has also been mainstreamed into the work that we do within our global Save the Children organization and through ministries of health, UNICEF, WHO, professional associations, corporate partners such as Johnson & Johnson and Laerdal, and of course with JPIGO, and other partners on the Maternal Child Health Integrated Program known as MCHIP. When we began this journey, relatively little attention had been focused on newborn health. In the early going, frankly, we were quite surprised that so few fully understood how important the issue had become. And many others doubted that much could be done about it, especially in the low-resource settings where the need was great. I think that Abe Bang's work in India initially, documenting that over 60% of newborn deaths could be prevented through relatively low-cost interventions that were actually delivered by community health workers, together with subsequent studies in places like India, Bangladesh, and Nepal, began to alter the prevailing view that little could be done to save these lives. We're in a very different place today. There's a dramatically heightened awareness of the issue and what can be done to prevent newborn deaths. There has been rapid issue ascendancy, as our colleague Jeremy Schiffman said in an article published in The Lancet, for the issue of newborn deaths, and in fact, that ascendancy was very rapid and now is on the agenda of many organizations. We see it reflected now in global and national policies and plans in many countries where we work. The evidence has grown as well, including evidence that what was done and learned initially in relatively small populations under more controlled conditions could in fact be replicated in larger health systems and programs. It in fact, and there is a consensus that was previously lacking about the place and timing of neonatal deaths, but also about the evidence-based technologies and approaches that can work in low-resource settings. We collectively have shown that much can be done and can have an impact, and can be delivered and prevented or promoted by frontline health workers, including, for example, provision of essential newborn care that impacts on all three major causes of newborn deaths, preventing and treating life-threatening newborn infections, kangaroo mother care, which we've just heard about in this video clip, intrapartum complications, such as a baby that is not breathing at birth, as well as the critical role of mothers, family members, and other caretakers in providing basic newborn care. We know that there's also a growing consensus around what I would call underutilized interventions, such as antenatal corticosteroids that offer the potential to further reduce neonatal deaths in many countries where we have worked. And we have achieved readiness as measured by a set of benchmarks related to the policy environment, political commitment, and positioning of newborn health as an important health intervention to go to scale. But what we have not done yet in any country, and particularly any low-income country, is achieve sustained, effective, and equitable coverage, meaning availability and use of quality care of what we know works. In fact, if current rates of reduction in neonatal mortality continued, it would take Africa over 140 years to reach the current rates of neonatal mortality found in high-income countries. So with the continued support of the Bill and Melinda Gates Foundation and USAID, and working in partnership with many of you in this room, we intend to focus our attention on those policy, supply, and demand-related factors that must be addressed if we are to move forward and to fully realize the potential that these proven interventions offer. In the process, we hope to learn much more than we know now about how to do that, and especially how to sustain those improvements once achieved. We know this will require political commitment and going beyond the usual suspects to find and engage new champions. It will require additional resources to support the introduction, strengthening, and expansion of these interventions within broader MCH systems and programs, and a much smarter approach to understanding and influencing household practices and care seeking as it affects the mother and newborn. We look forward to working with all of you as we continue on this journey, and over the next several days to learning from each other and committing to work together to take the action needed to accelerate progress towards ending preventable newborn deaths. And I must say that we're absolutely committed to advancing this agenda. And for those of you who were in the room last evening for the entertainment, we're prepared to commit Dr. Al Bartlett to join Yvonne Chaka Chaka on a global singing tour to help make this happen. Thank you.